So I'm going to finish off the research sessions with a talk about using artificial intelligence to predict outcomes for women with LAM. This is a collaboration between the Nottingham LAM group, mostly myself, also Jan, who's been working on the data to get that in an orderly and presentable form that we've collected from all of the people that we see at the LAM Centre. Most of the hard work, all the clever stuff really, was done by Culley, who's a postdoctoral researcher at the Advanced Data Analysis Centre in Nottingham, which is part of the Computer Sciences Department, where they use big sets of data to analyse appropriate problems. And the other person on the list here is Jonathan Garibaldi, who's head of computer science at Nottingham and Culley's boss. So, really, what's artificial intelligence and machine learning? Well, the way this works is that when you have a very large set of data, and one of the examples of that in common life might be people's internet browsing histories. You can see that the little sites that they click on and the orders of things that they do form patterns, and they're all related. So if you look at any articles about artificial intelligence or machine learning, what you usually see are these types of figures, and each one of these little dots is a piece of data, and you can see that lines join them. And so all of these little bits of data are related to other pieces of data, sometimes very closely, but sometimes not very related at all, and although they're related via other pieces of data. Now, trying to analyse all this using one human memory is a virtually impossible thing, and so nowadays we use computers to do this, and we use specialised techniques. And the thing that we use particularly is something called feature engineering. So what feature engineering does is it finds connections between different bits of data, between different variables. And it can understand how a little bit of this variable and that variable and a component of another variable are all related and commonly grouped together. And then you can map these onto new variables. And the importance comes, of course, when you can associate these new variables with something useful. So in medicine, for example, people are using this to recognise patterns on CT scans. And what we're doing today is to try and recognise patterns in the data from women with LAM and see if we can predict anything. So there's lots of examples of how machine learning is used in everyday life. For example, if you read the newspaper online, you'll see lots of adverts for things that you're interested in. So if I read the newspaper on one of the computers at home, I'll get lots of adverts about bicycles and guitars and other useful stuff. Whereas if my wife Jan reads the newspaper, same newspaper, very often the same computer at home, she'll get articles and adverts about shoes and greenhouses. And these are all tuned to different people's interests. And actually it does work because the greenhouse is actually being delivered in September. So machine learning is a useful thing that can be applied in lots of ways. So as far as this relates to LAM, I'm going to tell you about a little bit of work we've been doing employing some of these techniques to try and improve making prognostic decisions for women with LAM. So this is the clinical problem here. LAM is a rare disease, as you know, but it affects different parts of the body. And so some people have some features of LAM, some people don't, but they have other features. The disease also progresses at different rates. And when you see someone for the first time, often it's hard to tell which features they get and which way the disease will progress. For example, so this is a CT scan of someone with LAM. I'm always showing these at these talks. Everyone has a CT scan that looks a bit like this. These are the lungs, and the little black round circles, if you can pick those out, are the lung cysts. Now, everyone with LAM has those. Not everyone gets pneumothorax. So in some cases, the cysts leak and the lungs collapse. This is a CT scan with someone whose both lungs have collapsed at the same time. Now this happens to about maybe 2/3, 3/4 of people with LAM, but not everyone. Some people, this is a lung function test, get an improvement in their lung function when they use bronchodilator inhalers, the types of inhalers people take for asthma. And you can see from this little graph here, the smaller curve is the one before the inhaler, and the bigger one afterwards, showing there's an increase in airflow. But actually, only about 20% of people get this benefit. Some groups have suggested that the benefit with bronchodilator inhalers can be related to your future lung function change in LAM. This scan here, with the highlighted by the arrow, is a kidney angiomyolipoma. This is quite a large one. About half of people have these, but not everyone. About 10 to 20% of people will have these lymphatic changes. A few more will have LAM because they have tuberous sclerosis, a genetic disease. So not everyone has all these features. Some people have all of them. Some people have very few of them, only a few lung cysts. And so you get the feeling that certain patterns of LAM often run together. So you see some people, their first symptom of LAM might be breathlessness, or it might be a lung collapse. And actually these people who present with breathlessness or lung collapse might behave differently in terms of their LAM from people who present with things that aren't related to the lungs, perhaps from kidney tumours. And this is an important graph. Each one of these lines is the change in someone's lung function over a long period of time. So each line is a person. And so you can see there are some lines where the lung function never really falls over quite a long period, and others where it declines steadily over time. So if we could predict when we first saw someone whether they were going to get pneumothorax, whether they needed surveillance for kidney tumours, what was going to happen to their lung function longer term, that would be a very helpful thing to inform people about what was going to happen to them, and B, to make early treatment decisions. So the hypothesis and the aim of this piece of work really was based on the assumption that groups of clinical characteristics are associated with each other and might relate to patients' outcome. And we thought that if we could define groups of patients with different features using this machine learning technique, we might be able to use that to make treatment decisions, to improve the management of people with LAM, get people on treatment faster, reassure people about things that were less likely to happen to them. So a lot of you watching probably have taken part in this study. As you know, when people come to the LAM Centre in Nottingham, this is us with genetics and thoracic surgery and urology. Everyone gets invited to take part in research. So we consent them to use their clinical data for research projects to try and improve LAM. The first time they come, they get a fairly comprehensive assessment. They get a clinical examination, they have CT scan of the chest and abdomen, they have lung function tests, and often they have blood tests taken, and if they've had a biopsy before, we try and get hold of that with their consent. Then each time they come back to the LAM Centre, we find out what's happened to them in the intervening time, whether they've needed therapy for LAM or other conditions, and we also repeat their lung function, so we know what their long-term outcomes are like. So for this study, in the discovery cohort, so the group of patients that we used to assess whether the models worked, we used 173 women who definitely had LAM collected from the cohort at the LAM Centre, and for whom we had some outcome data in terms of what had happened clinically and their lung function. Whenever you do one of these types of studies, you then have to repeat it in another group of patients to make sure that this wasn't just a one-off finding because your group of patients is different from other groups of patients. So for this replication cohort, we used another large group, nearly 200 patients from the National Heart, Lung and Blood Institute registry in America, where they collected similar but not identical data over a different period of time. The other thing about the NHLBI cohort is that there's long-term outcome data because it was collected a long time ago. So we then use these machine learning methods on all of these bits of data. Just to cut a long story short, you make sure the data is valid, there's no mistakes in it. If there are missing pieces of data, you can estimate what those might have been using specialized techniques. You then turn the data into a format that can be analyzed by the machine learning techniques, identify how many groups of patients you might have within your whole set, and then associate these groups of patients with your outcomes. So it doesn't sound too hard, does it? So we started off with a lot of data. We had over 20 variables based around the age you were when you first got LAM, how long you'd had your LAM symptoms for, how you presented with LAM, whether you were breathless, whether you had a pneumothorax, or whether it was a kidney problem, whether you had tuberous sclerosis or lymphatic disease, how much estrogen you might have been exposed to in your lifetime, whether you were pre or post-menopausal, how many children you'd had, how active the disease were, so had you needed operations to fix pneumothorax, for example, what was your VEGF level, what was your lung function at baseline. So we had all of these data for both cohorts, which is nearly 400 patients or so. So just for the UK cohort, that was over 4,500 individual pieces of data. So, and this is what the data looks like. If you look at all these factors and you associate them, you can do this analysis called a principal component analysis and understand how the different bits of data relate to each other. And so, if this is the origin of the graph here, if each factor is near the origin, it doesn't really distinguish between one patient and another. So if you can see here, the number of children doesn't really tell you anything very much. Your VEGF-D level doesn't tell you a great deal, actually. Whether you've got tuberous sclerosis doesn't make a great deal of difference. But how old you were when you first got LAM, whether you'd had pneumothorax and how serious it was, pretty important. Lung function actually pretty important, both gas transfer, spirometry, and the walking test, how you maintain your oxygen, all important variables. So you can then analyze how many clusters there are. So this cluster analysis suggests that the optimal number of clusters will be 2 or 3. So after that, when you start getting, if you make lots and lots of clusters, you can see they're not really very different from the ones before. So we looked at 2 and 3 clusters, and this is how the 170 odd patients in the UK cohort group into 3 clusters. So you can see that each one of these ellipses or circles is a cluster, and some of the patients are strongly in one cluster, some of them overlap a little bit. And this is the 3 cluster model. And so each of these little graphs just shows you the age of the people, age at their first symptom in the different clusters, lung and their lung function. So, for example, the age at the first symptom, you have LAM, cluster 2 much younger, cluster 1 sort of somewhere in between, and cluster 3 are older. And that's the same for the age at baseline. And you can see that lung function also segregates according to the clusters. So this is my model for the 3 cluster analysis. So if we look at each cluster in detail, so the one I've highlighted here is cluster 1. So cluster 1 was the biggest cluster. So 2/3 of patients fitted into this group. They had their first symptom in the mid-30s. That first symptom tended to be breathlessness or sometimes pneumothorax. And when they presented, they had moderately impaired lung function, they had airway narrowing, and the gas transfer was reduced. And so, this is the sort of classic description of somebody with LAM. So we look at cluster 2 now. That was about 1/5, 20% of all the patients. And what you see is that they had their first symptom about 5 years before the patients in cluster 1, whereas the patients in cluster 1 had either breathlessness or pneumothorax. The patients in cluster 2 never had that. They nearly always presented with non-respiratory findings, particularly angiomyolipomas, so problems related to kidney tumours. These patients had pneumothorax about half as often as the ones in cluster 1, and their lung function was a bit better. Cluster 3 is an interesting group. This was only about 1 in 10 of women with LAM. And you can see that actually they're nearly 20 years older when they have their first symptom than the women in cluster 2. They never present with pneumothorax or breathlessness, and actually the chances of them ever having had pneumothorax are very, very low. Most of those people present with milder symptoms. So these other respiratory symptoms, that might be cough, and so somebody ended up having a chest x-ray that looked a little abnormal, or they had some other sort of problem, had a CT scan, and somebody noticed by accident pretty much that they had LAM. So we've got the classic patients with LAM, we've got patients who have lots of problems with angiomyolipomas, and what I also didn't say actually is that they have a relatively high prevalence of tuberous sclerosis in cluster 2. And you have cluster 3 who present slightly later and tend to have fewer respiratory problems. So these are just 3 example patients, one from each cluster, because these are clinically recognizable scenarios that when you look after a lot of people with LAM, this is what you see. So cluster 1, this is a person presenting with a pneumothorax, no kidney problems here. Cluster 2, this person presented with a kidney angiomyolipoma. The arrow highlighting this white area here is where she's needed an embolization for a ruptured kidney tumour. There's another small angiomyolipoma on the other side there. This person didn't know they had LAM at all until they had a CT scan because they'd been injured, and they had their whole body CT to see if they'd had any internal organ damage. And they hadn't, but what they had seen was this large cystic mass highlighted by the white arrow here, and this is a lymphatic mass. Patients in cluster 3 tend to have fewer symptoms, tend to have more lymphatic problems, and present a bit later. So the clusters are identifiable. So this graph here merely highlights that using this clustering system, we can apply our data to other patients. So this figure here shows the UK clusters 1, 2, and 3 in the dotted lines, and the same colour in the full lines are the American clusters. And basically, the closer that they lie over each other, the better the agreement between clusters. So apart from for angiomyolipoma, pretty much the agreement between the cluster separation is good in the American and the UK cohort. So that gives us confidence that this is a valid technique. So that's all fine, isn't it? So you can come and see me. I can go, oh look, you're in cluster 2. Is that really useful? Well, yes, it is. I mean, it suggests all women with LAM are not the same. But actually, you all knew that already, didn't you? The value of this really is that within the clusters, you can predict one thing from another. So usually, if you get troublesome pneumothorax, very often this happens to patients in cluster 1, you're much less likely to get lymphatic problems. If you haven't had a pneumothorax by the time you're 50, the chances are you're really quite unlikely to have one at any time. It's not never, but the chances are much less than someone presenting with LAM when they're 30. So the real use, of course, would be if we can put a number and predict some outcomes here. So clusters do predict outcome, it turns out. So when we find someone with an angiomyolipoma, we scan them every year, or sometimes a little less, depending on the features of the tumour, to see if the angiomyolipoma is enlarging or at risk of causing a problem in the future. And if they are, then we refer them for a potential intervention. So what this data says is if you look in cluster 1, moving forward from the time people were assigned to clusters to what happened after that, and this is a mean follow-up of about 5 years, 50% of cluster 1 have an angiomyolipoma, nearly everyone in cluster 2, and somewhere in between in cluster 3. The patients in cluster 1, if you look after 1,000 patients for a whole year, 7 of them will need an intervention for angiomyolipoma on average, but actually only 1 in cluster 2, and somewhere in between in cluster 3. So even though cluster 2 have had lots of problems with angiomyolipoma, once they've presented and it's dealt with, chances of that happening again is really quite low. And these are significantly different across the clusters. So this graph shows how likely you are to have a pneumothorax in the future. So if you were assigned to a cluster 1 or a cluster 2 here, this is slightly different from you. It's 3 clusters in this model, 2 in this one. So if you're assigned to cluster 1 or 2 here, each time the line goes up, it means another person's had a pneumothorax. So this is the percentage of the cluster. So if you look here over sort of 5 years or so, actually the incidence of pneumothorax prospectively moving forwards from the initial visit in cluster 1 is over 3 times as high as cluster 2, it turns out. So this is quite useful data for predicting risk in women with LAM and also perhaps considering which intervention to have. This is data from the NHLBI cohort. So this is the risk of needing lung transplant or someone dying from any cause, actually. And that first thing to look at is this is a very long time. So this is 400 months. So this is from their diagnosis, followed along for all of this time. The other thing I will say, of course, is all of these patients were looked after and collected about 20 years ago, so long before there was rapamycin, and none of these patients actually got treated with rapamycin. So the outcome is likely to be better now anyway. But if you look in cluster 1, you can see that patients in cluster 1 have a poorer survival than the patients in cluster 2 and 3, and actually the cluster 2 and 3 patients are actually very good survival-wise. And if you think how old the people in cluster 3 are compared with cluster 1, actually the outcome here is very good. When we get further along, these are fairly small numbers, but this is a significant difference between these groups. So we can use these clusters to predict how we look after your kidney tumour, how likely you are to get pneumothorax, and long-term survival. So we think, in summary, that machine learning has identified clinically relevant LAM clusters. Cluster 1, the person with classic LAM, so if you read an old textbook about pneumothorax and breathlessness in young women, that's exactly right. And we see cluster 2, who are people with a high prevalence of tuberous sclerosis and a very high prevalence of angiomyolipoma, slightly younger people with better lung function. And then we see a new group emerging of people presenting at an older age, in their early 50s often, with far fewer complications and slightly better outcome. So we think this will be helpful for managing these complications, pneumothorax, angiomyolipoma, and possibly survival. What I really want to do is sort of understand whether these clusters are really different. Is there something different about the underlying biology of these people, or is it just rate of progression is different in the different clusters? It doesn't really matter for prognostic purposes, it still applies. But it'd be interesting to understand what is underlying this biological difference, because it would tell us about LAM. The other thing I want to do, and I'm trying to get funded at the moment actually, is do a structured analysis, so look at everybody's outcome, and then use the machine learning to work in reverse to predict at that baseline when which patients are, based on their baseline features, are going to develop lung function loss, so we can target them early for treatment. So I'd just like to say thanks to everyone who comes to the LAM Centre and participates in research. I don't think anyone's ever said no, which is an unprecedentedly good thing. So thank you to everybody. Thanks to people at the LAM Centre, Sharon and Wendy particularly, and Janet, who was there previously, who helped collect the data and organise everything. Got the NHLBI outcome data from Frank and Nishant in Cincinnati. And of course, I'd like to say thanks to Debbie, Suzanne, Roya, Jan and Zoe, who work on LAM in Nottingham, and of course our funders.
And now let's see if Simon can hear us. And yes, welcome to the Q&A bit, just to talk back on that AI research. And I've got one question, which is really how often you feel you need to do that kind of research. Obviously, you're looking at data that is actually quite old, but clearly very effective. So do you kind of say, right, that's what informs us for the next 5 years, or do you kind of constantly refresh it?
Okay, so actually using data from the past is actually quite useful, because it does mean that we can we've got the follow-up, so we can look at the outcome over time in those same patients. So you do need to look at sort of data that's accrued over a long period. And the American cohort, where we've got follow-up data for a very long time, is helpful for the survival. So it's okay to use data from the past. Updating all the models, and do I need to repeat the AI analysis? Of course, as we get more biomarker data, we might be able to incorporate those into the model. So we can use our clusters, and then we can add in any new data. So if we get a good new biomarker that's also helpful, we can add that into the model and make it more accurate. And the more data we have in, the more accurate it will be. So it is a sort of thing that you can update progressively.
And actually, we've just got a question in from Slido from Joy Wadsworth. Thank you for this. What about if you have lymph cysts? How does that affect your cluster?
So the lymphatic complications do vary across the clusters, and the cluster 3, I think, has the highest prevalence of those. Which cluster you're in isn't due to one factor, though. One of the things about the machine learning is not just what variables you have, but how strong those are. So how old you are, for example, or the degree of lung function abnormality. They're also factors, as well as the presence or absence of lymphatic disease. So yes, the lymphatic complications put you into one cluster, and so the highest prevalence is cluster 3. But if you got LAM very early in your life, that might push you more towards cluster 1. And so it's not a straightforward relationship like that. It's sort of hard to guess which cluster you're in just from one piece of information. If I'm clustering a person, I'd run their data through the computer algorithm, and it would tell me.
And actually, we've got a general question from Chris Hemming, which is, has research been affected by the reallocation of staff due to COVID-19?
I'm afraid it has, actually. So the sort of laboratory research that Debbie, Suzanne, Roya, Zoe do is on hold at the moment. The research buildings are all closed at the university and have been for a few weeks now. So we've been concentrating on writing papers, planning and data analysis, really, rather than actually generating new data. I mean, you have to do that. And so we've hopefully made the best use of the time. But we're really looking forward to getting back now. And we're working about how we can work in the lab with appropriate social distancing. And there's a very complicated process, really, because there are lots of groups in our shiny new building, which is one of the advantages, but it does mean there's more complicated organising to do so we can get back and work safely.